Hello, I'm Bruce Gewirtz, Surgeon-in-Chief and Vice Dean for Academic Affairs, and we're here today with a new member of our faculty, Rick Kim, who's joined us as the Director of the Surgical Congenital Heart Program. Rick, welcome.
Thank you, Bruce. It's a pleasure to be here.
Well, we'd like to learn a little bit about you and about your field, which I know is a very exciting and challenging one. Where were you born?
Actually, I'm an East Coaster. I can't even consider the East Coast. I was born in Buffalo, New York, and grew up in a really small suburb of Buffalo called Williamsville, and then made myself made it out even further east. Went to boarding school in New Hampshire, and then Chicago for college at your alma mater, and then med school in New York, and then surgery training at Yale, and then heart surgery training in Philadelphia, and more heart surgery training in pediatric cardiac in Philadelphia, and then in faculty at Yale for a couple years, and then out to CHLA for about a decade, and then now here at Cedars.
When did you first become interested in congenital heart surgery?
That's a great question. You know, it started with cardiac surgery. You know, when you start in general surgery and you start doing your training, you get exposed to a wide variety of cases, and you always knew that you were interested in surgery, and you're always interested in both the technical aspects and the human aspects. But I distinctly remember going into my first heart surgery OR, and I was like, that's it. Like, this is it. And then two other corollaries to that. The first was when you start reading about different kinds of heart surgery and things, you hear about how pediatric heart surgery started, and it's a really recent field, and maybe the most recent fields of the major specialties out there right now, and just how it developed and what it took to start operating on these small children. And that was a major push to go into the field. And then my appreciation of the field again really changed when I had kids of my own. And once you have kids of your own, the perspective changes again, and it just made me really love and appreciate my field. So.
Well, I know that the field has changed so much due to the innovation and success of the generation before you and your generation, and I'm aware of the fact that the total number of people with congenital heart disease is now more common over the age of 18 than under, which is a tremendous tribute to the fact that you're keeping people alive and enabling them to survive to adulthood. Really, really remarkable. What do you think have been the most significant developments in the field that have allowed the success rates to become so much better?
A couple things. Number one is experience is the king in our field, and once the field became specialized in the hands of a small number of people, these small number of people really were able to help perfect some of the operations, and then it spread out really across the world. It's really unique in the sense that the congenital heart community is really an international one. So that was number one. And then the second thing, I think, is the fact that with the technologic advances in things like cardiopulmonary bypass, new forms of cardioplegia and heart protection, the surgeons were really able to slow down and take their time in the operations. And so the number of residual lesions, the actual outcomes of the operations in the very smallest and sickest kids just became better and better. And now I would think that for most of the lesions, the experience following congenital heart operations are really quite good.
Yeah, it's remarkable how closely scrutinized the outcomes are, and it ensures in a market-driven way that the patients get to high-quality centers. I remember once hearing Paul Ebert give a talk, and it had something to do with how tetralogy Fallot treatment had improved. And his hypothesis was that it wasn't one thing, it was a synergistic effect of many marginal slight improvements, and that these all collectively led to the improvements in outcomes rather than one awakening element. Would you agree with that?
Yeah, it's so true, and it's really interesting. First of all, Paul Ebert is obviously just a legend in the field, but tetralogy and the management of tetralogy really is representative of the developments in care over time. Tetralogy is the first blue baby operation, so it really started it all. And it started with shunting, which was creating an artificial blood vessel to help with oxygenation of the blood, and it started at Johns Hopkins, but that was the original operation that started everything. And then that led to the development of cardiopulmonary bypass, and then that led to starting to operate sooner and sooner. But the reason why I think tetralogy is so interesting is that even during my tenure of being a congenital heart surgeon, the push up until quite recently had been to go earlier and earlier. In other words, there's really two ways to manage tetralogy of Fallot. One is to do an initial small operation, in fact very similar to that initial operation done at Hopkins. It's called a shunt, and then that would be a palliative operation, and then 6 months later do the complete repair of the tetralogy. And while I was developing, the general sense had been it's probably better to do a complete repair earlier and earlier. And so all the major centers started really pushing earlier and earlier repair, and it got caught up in the whole ego business where surgeons said, well, I can do it smaller. And then a couple years ago, some really thoughtful people put together all the data and really started to look at it, and they found actually the initial approach of doing a shunt operation, palliating, waiting for 6 months, and doing it later in many circumstances was the better approach. So it's continuous involvement, but yet, being able to look at ourselves or look at the people in the field in a very objective fashion and say, actually, maybe we're doing something wrong, and maybe the old way is the better way.
Yeah, for our listeners, perhaps, the thing that's most amazing to me is if you think about these very small children, often premature, that you need to do heart operations on, and you think about the size of their heart. I wonder if you could tell the audience, what fruit or vegetable would you compare the size of a neonate's heart to?
Yeah, I love this. The size of a newborn's heart, I always say, is the size of a big strawberry. So it's something, we always say that the suture that we use is the size of a human hair. The heart that we operate on is the size of a strawberry. And the total amount of blood that is found in a baby is a can of Coke. So there are some technical challenges to the operation.
Yeah, well, that's what makes the field so extraordinary, that the surgeons that are successful as congenital heart surgeons going into it have to be A+. And I know that that's the case for you. And then the other thing is that in vascular surgery, which I do, we're able to know pretty definitively what we're dealing with before we go in to take care of someone. And it's my sense, and I'm sure it's been improved lately, but it was my sense from my training period that actually understanding what the nature of the anomaly was, the abnormality, was not so obvious. And it required tremendous intraoperative decision making to know exactly what the relationships were. And when you talk about the heart being the size of a strawberry, large or not, it just emphasizes how perceptive you need to be and adaptive you need to be in the operating room.
Yeah, I think experience is important. Experience is important to the outcomes, but I also think that it is an important statement of fact that the outcomes really also depend upon the team. Your anesthesiologists have to be great. The intensivists have to be great, and it's been a wonderful experience since I've been here. I got here in April of this year, and I guess that's about 6 months. And in rapid fashion, we've started doing smaller and smaller babies. We've done a number of cases of emergency life support called ECMO for the smallest of infants. We've had great lengths of stay. In other words, we're able to get our babies out of the hospital really quickly. And I think importantly here is not only were we able to provide great medical care, but I think what we've really focused on here are the human aspects of care, and really emphasizing things like kindness and thoughtfulness and consideration, not only to the families but amongst ourselves, amongst all the caregivers, and it's really noticeable, and it's a lovely place to work. And so that has been a really wonderful aspect of the care that we can provide here, but also of working here, and it's been a wonderful change for me since arriving.
Well, I know that comes from the top down, and from observing you in many settings, I can see that you set that sort of cultural standard. But you raise a really interesting point that I did want to explore a bit. It was my understanding when I was growing up and helping with these kind of operations with Herb Sloan and Doug Byrne at the University of Michigan, that there was tremendous stress that was experienced by the parents, which is of course understandable. They have the joy of having a baby and the despair of finding out that that baby's very life is threatened from the beginning of their life. And I was under the impression that the divorce rate among parents with congenital heart patients was extraordinarily high, and forgetting even about divorce, that the stress level of these folks was almost unbearable. What insights do you have about that, and how has that been able to change?
So, it's such a young field, and so I don't think I'm that old. I'm in my early 50s, but when I started in medical school, this is the early 1990s. Children who had a congenital heart problem did not routinely survive. In fact, one of the problems that we see commonly, hypoplastic left heart syndrome, the early to mid 90s, the mortality rate of a baby who had hypoplastic left heart syndrome was extraordinarily high. It's still high. And I can imagine that if you were the parents of a child who had a severe anomaly like that, the stress of the operation and having to take care of a child could be overwhelming. I think it's much better. In fact, I tell many of my families, obviously there are still kids who are really sick, but I tell a lot of the parents, I say that, something, it's okay. we're going to get through this. In many instances, the majority of instances, you're going to have your child do all those things that you want and hope for in your children, to run and play and to be happy and to go to school and to have families of their own. That's the case in the majority of patients these days. And if it's something more than that, that's okay too. We really work hard to kind of to optimize not only outcomes, but to really try and set up the situation where your child is growing with you. Your child is to enrich your life. It's the where you and your child are living a life together. It's not that horrifying thought of what happens when you have a really critically ill child, where your entire life revolves around the care of the infant. Of course, that can happen, and we work with those families also. But understanding families, taking care of the families as well as the child is really important to us as a program, and really important to me as a caregiver.
Well, that's so insightful. I have to share a personal touch here. I had twins with my wife in the early 80s, and we lost one of the babies in 24 hours from a hypoplastic left heart. And this was in 82, and there was literally nothing much to do for those children. They could have some temporary shunt and then potentially a heart transplant, but the likelihood of getting them through was negligible. And it's just one example of how this has changed so dramatically. So one final question that has always puzzled me, being someone that operates primarily on adults, when I put a tube in an adult, you described it as a shunt. In my case, it's sort of a bypass, a replacement for an artery. I can be relatively certain that the size of that tube is well selected for that patient for the rest of their life. So when you take a strawberry-sized heart and you put in a piece of mesh or a shunt or something, and how do you, conceptualize updating that as that heart grows into a grapefruit?
That's fascinating. So it's interesting, and it really, let's take hypoplastic left heart for example. It really comes down to the fact that as the child ages from a newborn to 6 months of age, the physiology of the heart and the lungs changes. And so initially, it just so happens that all babies are somewhere between 2 and 4 kilos. That's the size of a human baby, even small ones. And for babies that size, it's basically one of two sizes. And many times it's either a little too big or a little too small, but all those things that you can deal with. When it comes time to outgrowing your shunt, the physiology of the lungs has changed to the point where we can take the shunt out, and we replace it with a completely anatomic connection that does not rely on that little artificial blood vessel.
So then
anymore.
It grows normally
Correct.
as normal
Correct.
tissue.
Yeah.
Well, this has been just fascinating, and I hope to talk to you again, because I know the field is developing so quickly, and with the Guerin Pediatric Initiative here at Cedars Sinai, I know that the program that you and Evan Zahn run is going to become even more noteworthy and large. So, Rick, thank you very much for your time today. Really appreciate it.
Thanks so much for having me.